Hi, do you want to learn about ICD-10-CM general coding guidelines? Don't worry, I got you covered. This is Surya Johnson, your medical coding guide.
Hi, in today's video we'll see about the official ICD-10-CM coding guidelines. In that we'll see about the section 1B general coding guidelines. In my last video we saw about the section 1A conventions, right? So hope you're all clear on that. And in today's video we'll be covering the section 1B general coding guidelines. So as usual, grab your notes and your pen so you'll not miss any of the key points or important things that we're going to talk about, and we'll discuss in detail about all these guidelines. So in the section 1B general coding guidelines we see about 19 points. So we'll just see what are the 19 points are. The first one is locating a code in the ICD-10-CM. Number 2, the level of detail in coding. Then number 3, we'll see about the code or codes from A00.0 through the entire code list. Then number 4 is the signs and symptoms. Number 5, conditions that are an integral part of a disease process. Number 6, we'll see about the conditions that are not an integral part of the disease process. Number 7, multiple coding for a single condition. Number 8, we'll see about the acute and chronic conditions. Number 9, combination code. Number 10, sequelae or late effects. Number 11, impending or threatened condition. Number 12, reporting same diagnosis code for more than once. Then number 13 is the laterality. Number 14 will be regarding the documentation by clinicians other than the patient's provider. Number 15 will be syndromes, and number 16 will be the documentation of complication of care, and number 17 borderline diagnosis, and number 18 use of signs, symptom and unspecified codes. Then the 19th will be coding for healthcare encounters in hurricane aftermath. So we'll be discussing all these 19 general coding guidelines. These may, as I already told, these may look very meek or not of much importance, but believe me, you should, being a coder, you should know this in detail. Like, I'm not telling you to mug up or memorize all these things. Just make sure that you know what are these and what the guidelines are talking about. So we'll go to the number 1, locating an ICD-10-CM code. As I already discussed in the chapter 1 convention A, when we're talking about the alphabetic and the tabular list, you should first locate in the alphabetic index. Like, you should search in the alphabetic index. Like, for example, we'll see the patient has an iron deficiency anemia, then you'll be searching the A, anemia, and then under that you'll choose the iron deficiency anemia. Then after locating in the alphabetic index, what you're supposed to do is you should go and verify in the tabular list, because the tabular list will give you extra convention guidelines, notes, or whatever it is included, excluded, all these things will be there in the tabular list only. So you should first locate in the alphabetic index, and then you should second verify in the tabular list. Then the second one is the level of detail in coding. So the detail of coding, what does this mean? It means like what and all the highest number of characters available, it should be entered. Like we said before, if the code requires a 7th character, then completing the 7th character only will make or enable it to become a code. So you cannot code a 5 character when the code or the guideline requires a 6 or 7 character. You should complete, or it means you should put all the highest number of characters available to make it a complete code. So the level of detail in coding is needed. Highest level of specificity documented. What does that mean? So whatever the documentation, if the documentation is very specific, you should like try your maximum or your level best to get that specificity. Even you cannot put all the exact words from the documentation into codes, you should always try to maximum which is the nearest or the most specific diagnosis that very much suits this documentation. So highest level of specificity documented. For example, in this B80 enterobiasis. So enterobiasis, after this there is not much of a character subdivisions going on. B80 is the complete code. So in this B80 will be a complete code. J20.6, even it has only 4 characters, but this 4 will make it as a complete code because there's no more further classification beyond this. Like that, we see the J03.01, M25.251. These don't have a 7th character because it does not require. So the maximum character that has been classified will become a code. And this, the last code, S52.012A, has the complete 7 character because there is a classification and it has a 7th character, so is a code. The third one, code, are codes from A00.0 through T88.9, then we have the Z00 to Z99.8, and then we have the U00 to U85. So these are the entire code list. You should use like all these codes appropriately, like identifying the diagnosis, the symptoms or the conditions, the patient problems or the complaint or the reason for the encounter or visit. Based on all those criteria, you should choose the appropriate code from this entire list of codes. The fourth one is about the signs and symptoms. So when can you code a sign or a symptom? When there is no definitive diagnosis established, then you can code sign and symptom diagnosis. For example, we will see here urinary tract infection and dysuria. In this case, you should not assign dysuria as additional diagnosis code because UTI patient will have the symptom dysuria. So it is an integral part of the condition. So you will not code dysuria separately. Sixth one, conditions that are not an integral part of the disease. So we already discussed before in the 5th point. So signs and symptoms not associated with the disease, then you should be coding it additionally. For example, we will see the same UTI thing, urinary tract infection and runny nose. In this case, the patient's runny nose is not related or not an integral part of the disease of urinary tract infection. It is totally different. In this case, we will code the urinary tract infection and also the runny nose. Hope you got the point. The 7th one, multiple coding for a single condition. What is multiple coding for a single condition? So like for one condition, you use more than one code, like you'll use 2 codes or 3 codes. In which scenario you'll be using? You'll use an etiology and manifestation thing. You got right, like in the chapter first one, conventions, we saw about the etiology and manifestation. These are 2 different codes. Okay, and then you'll use this multiple codes. Whenever there is a word, use additional code. So if any applicable condition or symptom is there below the diagnosis under the use additional code, then you will be using multiple code. And the other one is the infectious disease code. So when there is an infectious disease, you'll code the infection and then the disease that is caused. So there is more than multiple codes. And then the other one is the code first. So wherever you see a code first node, it means before coding the diagnosis, you have to code first some other diagnosis. So it will be listed below itself from the code first. So it needs multiple coding for a single condition. The next one is code, if applicable, any causal condition first. In this case, code if applicable means if any causal condition is applicable to that diagnosis, then we have to code that also. And also multiple coding will be used in sequelae when there is like complication after something like an injury or some disease. After that, some time period, there will be some complications, right? Complications or after effects. These are called sequelae. Then OB codes, all the obstetric codes, you'll be using multiple codes because as per the guidelines. So these codes, whenever you see all these etiology manifestation, use additional code or infectious disease code, code first node, or code if applicable any causal condition first node. Then for sequelae, any complication or OB codes, you'll be using more than a single code for one condition. That is multiple coding for a single condition. So number 8 is the acute and chronic conditions. So if both acute and chronic condition exist in a patient, then you'll code both and you should sequence the acute condition first because it is the most, it is the high priority to be treated because it's acute and it's severe. So if there is both acute and chronic condition, you'll code both and you should sequence acute code first. 9th one, combination codes. So what is combination codes? Combination codes means there are 2 diagnoses, but it has a single code together. Like for example, combination codes means single code used to classify first two diagnoses, next diagnosis with an associated secondary process, that is the manifestation, then diagnosis with an associated complication. So in this case, if there is a code that describes two different conditions together, then we should code that single code. You should not divide and code two things separately when there is a combination code already available. For example, in combination code in the alphabetic index, you will see in the subterm entries, there will be subterm entries where you will see the combination codes, and in the tabular list you can check the inclusion and exclusion notes, so you will not code separately when it requires a combination code. So the number 10th is the sequelae. Sequelae means late effects, after effects. So what is sequelae? It is a residual effect. What is residual effect? Like some condition or some injury has happened to a patient, but after some time, say some month or sometimes some years also it takes, like it affects, it shows some other complications. That is the residual effect. So there is no time limit. It can be very early or in the late years. For example, after a burn cases, the patient after the burn, after some months, they will develop a scar, right? So scar is a sequelae of the burn that has happened to the patient. And another example is like an injury has happened to a patient long back. After some years or some month, the patient will develop sometimes. It's not like all patient will develop, but sometimes the patient might develop a cerebral infarction. So in this case, the cerebral infarction is related to that injury that has happened long back. So that's a sequelae. The next example is the patient has a tubal occlusion. After tubal occlusion, after some month or some years, the patient might develop an infertility. So this infertility is a sequelae of that tubal occlusion. Number 11 is the impending or threatened condition. So what is impending or threatened means that it has not occurred. It might occur if not the precautions or the treatments are taken. So it's not happening right now, but if it's untreated or any careless things happen, it might happen, it might appear or it might occur. That is called as impending or threatened condition. So in this case, if it occurs, then you will code it as confirmed diagnosis. All the occurred condition, that is the patient has it right now in the body, then it is confirmed diagnosis. You cannot code impending or threatened for the confirmed diagnosis. So if it did not occur, then we can code it as threatened or impending. So in this example, you can see threatened abortion. There is a code O20.0. So what is threatened abortion? There is no abortion happened to the patient, but the symptoms or the related signs reflect that it might happen. So all the precautionary actions should be taken or the treatment should be followed. So this threatened abortion has a separate code O20.0. So if it did not occur, and also the alphabetic index does not show impending or threatened word, like all impending or threatened condition will not have a specific code. Some, like threatened abortion, has a direct code. So in this case, if there is a direct code like for threatened or impending and they did not occur, then you can code. What if it did not occur, but there is no direct code that states like the patient is threatened or impending condition? In that case, you will not code at all. So now we got the point, right? So number 12th one is reporting same diagnosis code more than once, and it's a big no for this one. ICD-10 codes should be reported only once per encounter. You cannot repeat the same diagnosis in the same encounter. So number 13 is laterality. Laterality means the sides or which side. For example, if the document states it's bilateral, you should code bilateral diagnosis. In some cases or in some instances or some diagnosis list, there will not be any bilateral diagnosis directly. In that case, you will code right and left together. So you'll use two codes when there is no bilateral direct code leading to the ICD codes. So in this laterality, we will see like ICD M79.671 means pain in right foot and 0.672 means pain in left foot. So when it's right, you'll code this code, and when it's left, you'll code that code. When it is telling you bilateral, you do not have a bilateral pain in bilateral foot. In that case, you'll code two codes, right code and left code separately. So 14th one is the documentation by clinicians other than the provider. So in some scenario, there will be some documentation done by some other clinicians or healthcare professionals that is not the treating doctor. So who are the clinicians? These are the healthcare professionals who are permitted to document. For example, the nurses, dietitian, emergency medical technician, radiologist, all these people have the right to document, but they don't have the right to document in entirety. What do I mean? The nurses do not have the right to document the entire visit of the patient. They can document only the patient's blood pressure, the BMIs, or the patient height, weight, the pulse rate, whatever they are doing in their triage, they can document. And also, like for example, the dietitian can document all diet related thing only the dietitian can write. The emergency medical technician has the rights to document what and all is applicable and permitted as per their specialty, as per their role. So for example, BMI, coma scale, laterality, pressure ulcer stage, etc. These related professionals have the rights to document, and you can very well code these diagnoses if there is a diagnosis code. So now 15th one is the syndromes. So while coding syndromes, you should follow the alphabetic index guidance. So if the alphabetic index guidance has a diagnosis for a syndrome, then you'll go ahead and code that one for the syndrome related conditions. If there is no alphabetic index guideline, like the doctor has documented a syndrome, but there is no diagnosis directing to that in the alphabetic index guidance, then you'll code all the documented manifestation of the syndrome, what and all is manifestation recorded in the documentation. You'll code all those things separately. So number 16th, documentation of complications of care. So what you must have. So when you are coding for the complication of the care, it must have a cause and effect relationship, indication in the documentation that it is a complication. So what caused this complication, like how this thing occurred, there should be a documentation for that, and also what kind of complication it has led to, that also should be documented. If not available, the documentation, like it's not available for the cause and effect relationship, or there's no indication that there's a complication, in that case you should query the provider. For number 17, borderline diagnosis. So what is borderline diagnosis? Sometimes at the time of discharge, you should code the confirmed diagnosis. The doctor has documented this is the borderline diagnosis. Then in that case, because there is no confirmed diagnosis established, you can code the borderline diagnosis as a confirmed one. So if there is a specific ICD-10 for that borderline diagnosis, then you could specify that ICD-10 codes. So if you are still confused, like is this a borderline diagnosis or is it confirmed, or what is the final diagnosis by the doctor for this patient, if you are still confused, you can directly query the provider. Number 18th one, use of sign, symptoms, unspecified codes. So when there is no definite diagnosis established, then you can code the sign and symptoms. We saw like early in the same video ahead. So when you can code a sign and symptom, and when you cannot code a sign and symptom. So if there is no definite diagnosis established yet, you can code sign and symptoms. If there is no sufficient documentation available, like there is no specificity in the documentation, then you can go ahead and code that as unspecified code. So still, if you have any confusion, like whether to choose the sign and symptom or the unspecified code, in that confusion you can directly go and query the provider. So the 19th one is the coding of healthcare encounters in hurricane aftermath. So the use of external cause of morbidity codes, then the sequencing of external cause of morbidity codes, then you will take care of the other external cause of morbidity code issues, and then you will see about the use of Z codes. So what are the external causes? It can be a cause, like how it happened, and then the intent, in what type of intention this thing happened, or the place where it happened, and activity, that is what kind of activity was involved when that kind of cause has happened, and then the status, the patient's status when the external thing has happened. So you should assign all these things to identify the cause of the injury. This will not explain the injury, but you should assign all these things to identify how that injury has happened. And it cannot be given as a principal diagnosis, because the injury or whatever has happened, the condition or the sign and symptom will be the principal diagnosis. So these external cause codes about the cause, intent, place, activity or the status should not be given as a principal diagnosis, and these may be assigned in all healthcare settings. In all healthcare settings, these are applicable. And also they should be assigned for each encounter of care and treatment of the injury. You cannot tell like only at the first encounter you will code all these cause, intent, place, activity, status, external cause code. No, you will code for all the encounter till that treatment or that care has been taken care for that injury, till the entire treatment process. Whenever the patient is coming for a visit or for hospital admission or whatever it is, you will code this external cause of morbidity codes. In this 19B, sequencing of external cause of morbidity codes. So always the priority will be the cataclysmic events, and above all you'll be coding the child, adult abuse or terrorism. So all the external codes are there, and if there is a child or adult abuse or there is terrorism, these things precede all the external cause codes. And then you can assign as many number of external codes to fully explain the scenario or how the injury or the trauma or whatever has happened. So the 19C is the other external cause of morbidity code issues. So there might be some other condition that happened to the patient, like external causes that are not related to hurricane. In that case, you will assign appropriate external codes related to that also. And for example, there is some other external causes happen, but it's not clear whether it's because of the hurricane or some other thing. In that case, you will assume that it is a hurricane, then you will code that as the hurricane as cause and you will code. So addition to hurricane, if there are other possible codes like from the X30 series, X31 or X38 series, other causes are possibly like they are documented, then you can very well code. So in 19D, use of Z codes. If there are other reasons for healthcare encounters, it may be assigned as appropriate to further explain the case or the cause or whatever thing has happened, and the reasons for presenting for healthcare services, including transfers between healthcare facilities. You can code the Z codes. Also, you can provide Z codes to provide additional information relevant to a patient encounter. So finally, in this 19th point, don't confuse yourself. Whatever is documented after an hurricane and hurricane aftermath, you will be coding everything, all the applicable codes. What is the cause, the intent, the place, the activity and the status, everything you'll code. And then you can code as many codes as possible to fully explain the scenario. Okay, and then the use of Z codes, we saw like what and all additional information is relevant in the patient's encounter, code everything. Simple as that. Hi, hope you all understood this general coding guidelines, that is the section 1B of the ICD-10-CM coding guidelines. It might look simple, as I already told, it might look simple or it might look like not much of an importance, but I again repeat that being a coder, you should know your guidelines well. If you have any doubts in this chapter, please feel free to put it in the comment section below. I'm more than happy to answer all your queries.
Hi, if you found this video to be useful, please hit the like button. That will really mean a lot to me. And if you're new to this channel, please subscribe and hit the notification icon so you'll not miss any of my future videos. This is Surya Johnson, your medical coding guide.